Dear audience, welcome to my 18 months progress report, and let me present my PhD topic, which is New Insight in Cachexia Prevention in Gastrointestinal Cancer. My name is Bettina Budai. I'm a dietitian and a second-year PhD student. My vision is that nutrition is a cornerstone in the multimodal care of all cancer patients, and my mission is to carry out scientific activity to bring innovation in the nutrition therapy of cancer. To achieve my vision, I have two ongoing projects. In the first project, we investigated the risk factors for malnutrition in gastrointestinal cancer. And in the second project, we plan to investigate the effect of amino acid supplementation in the same cancer population. The first project started in September 2022. The prevalence of malnutrition in gastrointestinal cancer is up to 30 to 90%, depending on the tumor site and tumor stage. It has been estimated that up to 20% of patients die due to the malnutrition rather than due to the tumor itself. A lot of different factors can contribute to development of malnutrition. For example, poor nutritional intake, involuntary weight loss, fatigue, or pain. These symptoms are strongly related to the presence of inflammatory markers and the upregulated immune response. The inflammation can be worsened by the pro-inflammatory cytokines produced by the tumor, like TNF-alpha, interleukin-6, or interleukin-1. For example, in the muscle, the anabolic and catabolic imbalance can lead to muscle wasting, decreasing the muscle mass and the muscle strength. Or in the liver, the acute phase protein production is increasing, repressing the drug clearance and increasing the risk for the anti-cancer treatment toxicity. Worldwide, the prevalence of malnutrition is still underestimated by physicians, making it hard to identify those patients who are at high risk for developing malnutrition. So our aim was to investigate the risk factors for malnutrition in gastrointestinal cancer. We asked the question, what are those risk factors? And we hypothesized that we can determine some specific clinical and biological factors. After the systematic search, we identified more than 300 eligible articles. To make our result easy to follow, we categorized the risk factors into 5 major categories, like the population characteristics, the tumor characteristics, the laboratory parameters, the presence of different comorbidities, and the administered anti-cancer treatment. The outcome as malnutrition was assessed by different screening tools. Some of them were based symptoms like involuntary weight loss, decreased food intake, or BMI. The biochemistry-based assessment tools measured malnutrition according to immune parameters like serum albumin level or total lymphocyte count. In 2018, the GLIM criteria were established for the diagnosis of malnutrition, requiring 1 phenotypic and 1 etiological criteria. We also included all of the articles that measure in cachexia, even though there is no clear consensus regarding the definition of it. In the first aggregated forest plots, you can see the association between population characteristics and the malnutrition risk and diagnosis. Age above 65 means a higher odds for malnutrition, regardless of cancer type and cancer stage. Also, females tend to have a higher odds for developing malnutrition, except in hepatobiliary cancer. For example, in fatal papilla tumor, there is almost 60% higher odds for developing malnutrition in males compared to females. Here we demonstrate the association between biological parameters and the risk or diagnosis of malnutrition. I would like to highlight the result of inflammatory parameters. In general, elevated CRP can be seen in cachexia or at the diagnosis of malnutrition. In our analysis, the risk of malnutrition was almost 3 times higher by their elevated CRP level. When we look at the other inflammatory parameters, there is a clinically relevant higher odds for developing malnutrition by their elevated serum levels. Some certain feature of the tumors can increase the risk for malnutrition. For example, in colorectal cancer, there is a higher odds for developing malnutrition when the tumor located in the colon compared to rectum cancer. Moreover, the likelihood of malnutrition is 60% higher in case of right-sided colon tumor compared to left-sided ones. In general, the administered neoadjuvant chemoradiotherapy can increase the risk for malnutrition. In esophageal cancer, we can see these higher odds if the malnutrition was measured by biochemistry laboratory-based risk assessment tools. Symptom-based assessment tools may underestimate the risk for malnutrition in this clinical scenario. The strength of our meta-analysis is the transparent methodology, that we could analyze more than 100,000 patients' data. We could determine cancer-specific risk factors and the reliability of screening tools for certain clinical scenarios. Of course, we had to face some limitations. Most of the studies were retrospective cohort studies, and the heterogeneity through the articles regarding the cancer stage and the variety of screening tools. In conclusion, we could find out that inflammation plays a crucial role not only in cachexia or at the diagnosis of malnutrition, but also at nutritional risk. Till that time, there is no clear suggestion which assessment tools shall be used in certain clinical scenarios. With our data, we could make further steps for a personalized approach for malnutrition screening, promotes the early detection of patients who are at high risk for malnutrition. Further studies needed to find out how the pro-inflammatory cytokines affect the nutritional status. Drug therapy may have an important role with the reduction of inflammation to postpone or even prevent malnutrition. Currently, I am ready with the article. They are approved by the supervisors, and I plan to send it to internal review in the next couple of days. Our targeted journal is JAMA Oncology. In my second project, we plan to investigate the effect of amino acid supplementation in gastrointestinal cancer. At the diagnosis of cancer, all patients have to be screened for malnutrition and offered nutritional support as needed. Patients who should undergo oncological treatment, the presence of malnutrition can increase the toxicity, decrease the performance status, quality of life, treatment response, and overall survival. There are contradictory data regarding the proper use of amino acid supplementation. Some data suggest to use branched-chain amino acids to improve the fat-free mass, and some suggest to use glutamine to prevent mucositis. So our aim is to evaluate the efficacy of amino acid supplementation in gastrointestinal cancer. We are going to investigate patients with GI cancer. The intervention is going to be amino acid supplementation. As an outcome, we are going to assess nutritional status, quality of life, and survival. As a summary, I would like to say the submission date for the first project is February this year, and we plan to submit our next manuscript by the autumn of this year. I would like to thank you for your attention with this quote. Impossible only means that you haven't found a solution yet. Thank you.
So do you have a cutoff value of the CRP which shows you a better prognosis from the viewpoint of the nutritional status or risk of malnutrition? Or so can you give me a cutoff, please?
Thank you for the question. In our analysis, we could only conduct the meta-analysis part if we only compared decreased or elevated CRP level. So I think further study is needed regarding this, and this will be very important, as I mentioned, by only the risk assessment phase to have a real cutoff value and to identify those patients who are at high risk.
Can you use the CRP as a measurement of your therapeutical success, for example? So is it a good thing to decrease the CRP with a nutritional support? Can the patient have a better prognosis from his nutritional status?
Mm-hmm. At this stage, what we know that, as I mentioned by the GLIM criteria, it is a very important aspect that inflammation can have a negative effect on the nutritional status. And so that's why I think it would be very important. So at that time, there are some drug therapies that may have a good impact on the nutritional status, but these are not in a daily clinical practice.
Regarding your second project, do you intend to check only those patients who are under curative oncological therapy, or best supportive care patients also would be included in this?
As I see the literature, there are mainly the articles including those patients who has to have curative treatment. For example, in the preoperative status, they are receiving amino acids or other immune nutrition therapy.